Prompt started, training in our own department started in the year 2000, or a tiny bit before 2000. We were originally funded to undertake some research looking at the best way of managing obstetric emergencies. And what we did was randomise all the 8 units in our region to different sorts of training, training locally in their department and training in a simulation centre with and without teamwork training. And we performed about 450 different evaluations of some of the emergencies that can happen in labour, some that require just individuals to manage it, and some that require teams to manage these complications. And we really uncovered a lot of really interesting findings. So, for example, we established that less than 50% of working obstetricians and midwives in our region could do anything more than the basics for some emergencies. And that's not because they're poor practitioners, it's because actually training for rare emergencies is very difficult to access. And before 2000 there really wasn't very much in the way of kind of effective training or models for us practitioners to kind of train with. And we established that there were definitely better ways of training. And we folded that information into a kind of training course, which is now called PROMPT, so Practical Obstetric Multi-Professional Training. And we started using that in my own department in Bristol, so we're about 6,800 births a year, quite a big unit. And we started training in 2000, and we demonstrated that if you trained people effectively to do the right thing more often, then we could actually reduce that harm, reduce that preventable harm. Things that we don't need to happen could be prevented and reduced. And in our department there have been very significant associations with the training. So there's been a 50% reduction in babies born in poor condition, babies born with hypoxic ischemic encephalopathy, a 50% reduction in babies born with an Apgar less than 7 at 5 minutes, a significant predictor of cerebral palsy in later life. There's been almost 100% reduction in brachial plexus injury after shoulder dystocia, a complication where the brachial plexus nerves get damaged by inappropriate care sometimes in shoulder dystocia. We've also been able to see process improvement. So decision delivery interval is the time taken from the decision to deliver a baby urgently to their actual birth or delivery. And by training people to perform what we call a category 1 caesarean quicker, we have reduced the decision delivery interval from 23 minutes to 17. And that has been associated with safer anaesthetic and better outcomes for babies. Now, I think the most exciting thing really is not that this works in Bristol, but it also seems to work in other areas too. So in the States, they've had exactly the same outcome benefits to babies born in poor condition. Interestingly, they've also reduced the caesarean rate in the States, which is really exciting. And also the Vic Prompt pilot here in Australia is just about to publish, demonstrating exactly the same effects again. So 50% reduction in babies born in a poor outcome, babies born in poor condition.
Cultural benefits are that we get to know each other. We work in here at Sunshine Hospital, very big hospital. So especially from the anaesthetists, they've been very engaged because they don't have a lot of exposure to obstetrics, but when they come, obviously we need them for a fairly significant reason. And they've been able to at least know some familiar faces when they come onto the ward. It's also resulted in establishing some changes in our practice as well. So we've been able to instigate to get some new equipment, just in relation to notifying and getting staff to emergencies quicker. It's just not measured, but the perception is that they feel more confident in being able to call for that emergency help a lot more quicker than what they were previously. So they're probably the main things, but I think it goes back to that multi-professional training part of the training. You get more familiar with working with each other and feel more comfortable in calling for that help early.
I think what's been really interesting having a look at it in Bristol, where we are, is actually it's become an accepted part of everyday life. And in fact, we had a very interesting piece of work where some social scientists came to investigate the training at Bristol to try and understand it in more depth. And they interviewed a whole load of staff. And one of the midwives said, it's completely different now. We don't get staff crying you don't find any midwives crying in their cars in the car park after a shift anymore. People feel better equipped to kind of do the training. And I think we can use data to improve that sustainability by demonstrating to staff, look, we're doing the right thing. We're getting the right outcomes for mothers and babies. And now I think it gets to the point almost, nearly 15 years later, where it's become so embedded and so part of the system in the department that everybody actually wants the training. It's not a question of trying to persuade them to do it. And I think it's one of those things where we have to make it sustainable, we have to align priorities of government, priorities of insurers, priorities of women, so that we can actually align all these things to get the best outcomes for staff. And I think once we do that, then the sustainability definitely comes.